Yeah. So how many? How many? What is the average? Dr. Jaswinder, you are on mute, I guess. We are not able to hear you.
Maybe 400.
I
400.
have no clue.
400 maybe.
You had two kids, right? So your menstrual periods might have been reduced. Okay. So roughly speaking, 350 to 400 cycles an average female can have throughout her throughout her reproductive age. That is an average, like maximum 300 to 350 to 400 cycles you can get. Okay. It will alter with the number of deliveries you had, and also if you had any hysterectomy or if you are on any OC pills. But roughly, so we have 4 million follicles. Out of that 4 million follicles, we are only maturing 450 follicles on a maximum side. Rest all the follicles are dying in atresia. That is the fate of the follicles.
Limited edition.
Limited edition, yes. So we all are limited editions.
I know.
Right. So yeah, so we all are limited editions. So that is how and that's why it is being said that, have you heard that a very common phrase that you were present in your grandmother's womb? Have you heard that phrase? Let me repeat it. You were present. Why is like maternal
Yes.
grandmother? Okay, maternal grandmother. Why are we connected more with the maternal grandmothers? Because you were present in her womb. Why?
Yes.
Because your mother had all the follicles when she was born.
Yes.
Yeah. So that is the connect, the 3-generation connect. Yeah, it's just on a funnier side, just on a lighter side. Okay.
But it's true.
It's true. It's true. It's true. We are connected more towards the maternal grandmothers. Yeah.
So we have the answer today.
Sorry?
Why we have the answer today? I'm saying, why is it like that? We have the answer today.
Yeah. Why is it like that? Yes, that is yes. We got the answer today because we were in her womb, right?
Yeah.
So now, coming back to the ovaries and the functions of the ovaries. Ideally, this is the case scenario that thousands gets recruited, only 8 to 10 reaches to a phase of maturation, and only one gets matured. Rest all dies under the process of atresia. And these follicles, which are maturing follicles, they are releasing the estrogens, progesterones, and androgens. Okay, the maturing follicles are releasing these hormones. Now, the most common dysfunction an ovary can face is PCOD or PCOS, polycystic ovarian disease or polycystic ovarian syndrome. Right? Polycystic ovarian disorders like PCOS, we are commonly terming them as PCOS. Now, do you know how common PCO is? It is very common. I don't know about the Indonesian statistics, but in India, it's a very common finding.
In Indonesia.
Even in Indonesia? Yeah.
Yes, ma'am.
Yeah.
It is now becoming even more common with so much stress and all coming up.
Yes, it is definitely becoming very common because of the stress, the unwanted the unwanted lifestyle changes and all these things. Very rightly said, Dr. Jaswinder. Okay, there is a question in
And it's a very alarming thing, ma'am, actually.
Yeah.
I run a female fitness center, and I found there out of 10,
Yeah.
even 6 girls are affected with PCOS.
Sorry?
Out of 10, every 6 girls are affected with PCOS, but who are coming to me.
Right, they
The
are
young girls, actually.
young girls. It
It's
is
an alarming situation.
It's a very alarming situation. You just just a minute. There is just a question in the chat box. I'll just quickly look at it. To clarify, we have a period this month. Is it from the follicle that underwent maturation a year ago? Yes, it is from the follicle which got into the cycle of maturation a year ago. Okay, so this month, if you got a period, that means that follicle was recruited an year ago. It got into the fight of maturation, it won and it ruptured and it didn't conceive, so you menstruated. Yeah. Yeah. Okay.
I think the PCOS and PCOD has become one of the reasons why they are now saying, pregnancy has become more pathological than physiological nowadays.
Exactly. Pathology. I so agree with you. I so agree with you, Dr. Jaswinder. Pregnancy has become more pathological than physiological. I mean, there are certain places in world where the young population is declining. I mean, we are in India where the population is booming. That's a different scenario. But the countries like Bulgaria, Hungary, Japan, Belgrade, all these countries, they are having lack of younger population. I mean, the younger population, they have more older population because the female fertility is declining alarmingly, and the government is declaring prize money for those couples who are conceiving. Okay, so it is that it will definitely not happen in India, at least in few more years, coming down years. We are a very populous country, but in certain countries,
But still in our countries, lately, last 2-3 years, I've been seeing patients who say that humko nahi chahiye bacha. We are happy without, in spite of being normal without PCOS because of the stress of conceiving. Like it's becoming pathological, as we said. So people are like, ye sab jhanjhat nahi chahiye. Most of them are professional, so they don't want to. तो इंडिया में भी हो ही जाएगा अभी नहीं तो बाद में शायद.
Yeah, but we would be, I don't know, very old by then. So if we think about the IVF centers everywhere. So, yes, Dr. Jaswinder.
Yeah.
No, your voice is not
No,
clear.
okay.
Hello, are you saying okay? Are you saying something?
Yeah. No, it's okay. Fine. You
Yeah.
continue, please.
Yeah.
Oh.
So when we talk about the PCOD or PCOS or the menstrual irregularities, one thing we can easily find out or we can correlate is that you just see the place you are staying or the country, the city you are staying, and just look around. There are so many IVF centers which are popping up like mushroom tops. Every other street, every other corner, you will have at least there is a situation here in India. And when I went to Philippines, to Dubai, even there the situation was same, and even in Bangladesh, there are so many females who were having PCOS and PCOD and a difficulty to conceive. So it is a very common finding. Now, what exactly happens into this dysfunction in PCOS and PCOD is basically what should happen. Thousands are getting recruited, only 10 are reaching a phase of maturation, only one is getting matured and the egg is released. Okay, or maybe two are getting matured and the egg is released in case of twin pregnancy. In PCOS, thousands are getting recruited, majority of them, they are dying and they're getting absorbed, but another remaining one, they do not mature, nor do they die. I mean, nor do they get absorbed. So a follicle should have two fate only. A follicle, one fate is you mature and you release an ovum. Second fate is you disintegrate and you get reabsorbed in the body. But if a follicle, it does not matures, neither it disintegrates, then what will happen? Then this follicle will get converted, this failed follicle will get converted into a fluid-filled cavity. A fluid-filled cavity, which is known as cyst. A fluid-filled cavity is known as cyst. And when a female has multiple cysts in the ovaries, That is known as polycystic ovarian disease. Okay. Now, okay, this is the pathophysiology. What is polycystic ovarian disease? So, a ovary which is loaded with premature follicles, or which is loaded with failed follicles, they do not have an egg inside. Okay, they do not have an egg inside it. They just have the fluid filled cells, and these cells, the worst part of this is these cells, instead of releasing estrogens and progesterones, these cells will release excessive androgens. Okay, they will release excessive androgens, and excessive androgens are responsible for the characteristic feature of PCOS, like acne, baldness, hirsutism, facial hair growth, obesity, anovulation, and all these things. So that is a consequence associated with a PCOS, or with a, like, that is what is the PCOS. Okay. Now, why does this happen? Yes, yes.
Ma'am, I just wanted to confirm, one of my patient, she came to us with the irregular cycles. She was having thyroid and she got married last year. But now, after her ultrasound and all those tests, it is ruled that she doesn't have any cyst in her ovary, but still she is under the influence of PCOS. But now the doctor has really told her, gynecologists have told that you are on the menopausal phase in the year of 32.
Sorry?
She's not having her cycle from last 1 month.
Huh?
She's not having her cycle from last 1 year. But now the doctor has confirmed that you are on a menopausal phase in the
Right.
year of 32.
Yeah. So that is a early menopause.
Yeah, ma'am. But the endometrium is almost normal. It is almost thick.
The endometrium is thick, but what about her ovarian reserve?
Ma'am, it was okay. Ovaries were okay. No bulky size, nothing.
Then ovaries are okay, but what about the ovarian reserve? I mean, what the ovarian reserve is being counted by the AFC. That is the, just a minute. Yeah.
Ma'am, I will surely forward the reports to you.
Yeah, you share her reports to me, because early menopause, or a primary ovarian insufficiency, what happens into those cases, the primary ovarian insufficiency or early menopause is a finding of that the females might because of, again, stress, lifestyle disorder, maybe under the influence of some hormones and all, or maybe because of a pituitary benign pituitary lesion, a pituitary tumor, or also
She's having thyroid. She's having thyroid.
She's having a thyroid dysfunction. Okay, so
and hormonal imbalance. That is why she was ruled for PCOS.
yeah, so but she's not been diagnosed as PCO. Instead, she's diagnosed with a menopausal age, right? I mean, menopausal female.
Yes, ma'am.
That's what you are saying, right?
Yes, ma'am.
Yeah, so that is an early menopause. And early menopause can
at the age of 32. At the age of 32.
It can happen. So there are multiple reasons for early menopause. That's what I'm saying. It can be, the menopause can be due to, is she ruled out for any pituitary abnormality?
No, ma'am.
Maybe that would be into the plan of care, or maybe the gynec might have told them to just rule out a pituitary insufficiency, because at times it can happen that the ovaries are good, ovary reserve is good, ovarian reserve means what? How many amount of follicles are left inside the ovary. So if you see a post-menopausal female, she will not have any ovarian reserve left, means her ovaries are empty. Now she is not, no matter what you do, she'll not be able to get her periods. Okay, but into a pre-menopausal, or into a young female, okay, she might have a good ovarian reserve. So how to calculate the ovarian reserve? They calculate it through AMH, that is anti-Mullerian hormone count, and by AFC, antral follicle count. So they count that how many antral follicles are there and what is the level of AMH, and according to that they say that what is the ovarian reserve. So if the ovarian reserve is good and she is not getting periods, that means she might have a pituitary insufficiency. It can happen that maybe because of an adenoma or a benign pituitary tumor, pituitary is not releasing FSH hormone. So her FSH level is low. And because her FSH level is low, she is not getting her periods regularly. Can you correlate this? Either that can be a thing, or primary ovarian insufficiency or premature ovarian failure can be due to endocrinological disorder, can be due to a space occupying lesion, can be or either or there are chances that she actually has got her menopause. So you need to rule out that whether ovaries are done, they are done and dusted, they don't have a follicle remaining, or ovaries have a follicle, but the pituitary is not sending the signals for menstruation. So if the pituitary is not sending the signals for menstruation, then what is the reason for that? So whether it is a tumorous condition, whether it is a space occupying lesion, whether it is in whether or there is some compression on the pituitary, what the reason is, and then you have to normalize it. So if there is a pathology, a known pathology which is limiting the release of FSH and follicular maturation, that can be taken care of. But if the ovarian reserve is not there, if the ovaries are not having any follicles, that means it is a menopause. And early menopause is common nowadays, because early menarche is also common. I am seeing girls who are 8 years old, 9 years old, and they are getting their periods. So you are just
Yes,
8
ma'am.
years and 9 years and you got your periods. So the menarche is also becoming the menarche is also reducing in age, and so is the menopause.
Yes, ma'am.
Hmm.
Thank you, ma'am. I'll surely share the reports.
Yeah, you can definitely share the reports with me. Yeah. So are we good so far? Now, what happens into PCOS? Yes, Dr. Heta, you want to ask something? Okay. Tell me. Okay. So when we are talking about the PCOS, in the PCOS, the basic pathology, what happens in the ovary is this. In the ovaries, the follicles, they fail to mature, and they fail to mature. Moreover, they fail to get absorbed, and that's why they get converted into the cyst, and that cyst is releasing more amount of androgens instead of the estrogens and progesterone. Now, when the now what happens next, and why does this happen? Why does a female get a PCOS or a PCOD? So she can get a she can get a PCO. Now, what is the difference between PCOD and PCOS? Can anyone tell me the difference between PCOD and PCOS? Okay, so the PCOD, polycystic ovarian disease, okay, that means only the ovaries are showing the insufficiency. There is no other associated metabolic pathology to it. Okay, there is no other associated hormonal imbalance. Only the ovaries are having multiple cysts, and that presentation is being visible right from a very young age. That is PCOD. PCOS, polycystic ovarian syndrome, that means the female is having multiple ovarian cysts, and along with that, she has excessive hormonal abnormalities like thyroid dysfunction, or diabetes, or hypercholesterolemia, or high blood pressure. Okay, so if there is an associated metabolic disorder, it is polycystic ovarian syndrome. It is a syndrome, has multiple aspects to it. If only the ovaries are being damaged and only there is no other hormonal alteration, then it is a polycystic ovarian disease. So that is how, what is the difference between the disease and the disorder. But the line of treatment, medical or non-medical, conservative, the line of treatment is the same, whether it is whether it is PCOD or whether it is PCOS. The line of care remains the same. So nowadays, the gynecologists are not separating it to be PCOD or PCOS. Rather, they are just writing PCOS. P and CO and small s, PCOS. Whatever it is, the treatment remains the same. So they are just writing it to be PCOS. Okay. Now, when we talk about the PCOD or PCOS, what are the causes for PCOD, PCOS? What causes PCOD or PCOS? Yeah, can anyone tell me what are the causes?
Hormonal imbalance,
Yes, hormonal imbalance. Then
stress also increases it.
Dietary food.
lifestyle, anxiety,
Lifestyle, yeah.
Packaged food
food,
with preservatives.
preservatives, yes, added chemicals,
Posture.
Mm.
genetics, yes,
Working at various hours, night shift or something like that.
an altered sleep wake cycle, yes. Okay, so not posture directly, like in what sense are you saying is, doctor? Can you just explain how the posture you are trying to relate it with?
Sedentary lifestyle.
Okay, posture and sedentary lifestyle, yeah, that can be. Okay, so when we are you see, if I don't know, I can just say one thing that like here we have Dr. Jaswinder, and I think she would be the eldest of everyone present here. I mean, she is yes, Dr. Jaswinder, if I'm not wrong, you are above 50, right?
No, I'm going to be 60.
Yeah, she's going to be 60.
Wow.
Yeah, so she is the eldest, so she'll be able to correlate it better, that when you were young and how was your lifestyle, what was
Yeah.
your eating pattern, and what was the level of stress you are living into. And
Yeah.
now when your kids are young, or when your daughter is young, I remember you have a daughter as well, right?
Yeah.
Yeah. So when your daughter is young, and the level of stress, the level of the lifestyle and the pollution they are living into, it
Yeah.
is in
There's
drastic.
a lot of difference. Yeah.
Yeah. And
There's a lot of difference.
during your time, conceiving a baby, getting pregnant was not that of
It
a
was
big
not
deal.
not a problem. It was not a big deal.
Yes.
And nowadays it has become very difficult. Even my daughter-in-law, she had a PCOD. It was difficult for her to conceive. Then my daughter, who's a gynecologist, gave her treatment, and then she conceived.
Right. So it is that commonly present. I mean, in all age groups, in all socioeconomic condition also, as well as in all spectrum, educated, uneducated, obese, thin, everyone is suffering through it. Why? So the PCOS, when we try to understand, can be categorized into further subtypes. It can be categorized like stress-induced PCO, insulin-resistant PCO, post-pregnancy PCO, and then chronic inflammatory PCO. Stress-induced, I'm repeating myself, stress-induced PCO, insulin-resistant PCO, post-pregnancy PCO, or a chronic, chronic inflammatory PCO. What does this mean? What does these four types mean? So when we talk about the first type, the stress-induced PCO, there are many studies and many clinical trials which are showing a positive correlation between stress and the cortisol hormone. Now, when a female is under stress, that stress can be a mental stress, it can be a emotional stress, it can be a physical stress. Okay, whenever, and but particularly that stress is a negative stress. Even the stressors can be two types. One is a positive stress, another is a negative stress. Positive stress means the stress which you normally get before your exams, or which um, helps you or pushes you to do something good and achievable. That is a positive stress. Negative stress means the stress which is unwanted in the life, the stress which is cringing and crippling you down. It's not it is not taking you up, it is pulling you down. That is an unwanted negative stress. So whenever see, reaching you have to reach your college at your workplace at time, and you are running out of home, so that is also a stress. But when you are reaching the college at time and you are punching and you saw that yes, you are early, yes, you did it, so you achieved a goal, and so you are releasing endorphins. So that stress is a positive stress. It is ending up into a positive result. But when you are into a negative stress, or when you are into you are stuck by the negative things in the life, that is not releasing endorphin, that is not releasing oxytocin or dopamine. Instead, that is releasing cortisol. Now, when the level of cortisol increases in the body, it increases the androgens in the body. And when the androgens, there is too much biochemistry associated. So I'm not going in detail of the biochemistry here. I'm just giving you an insight. So when your, when your body is releasing, when you have lot amount of cortisols in the body, your body will release higher amount of androgens. And these androgens will limit the ovarian function, resulting into PCOD. Oh, sorry, resulting into PCOS, PCO. So that is the stress induced. Second is the insulin resistance. So when we talk about the insulin resistant PCO, what do we mean by the insulin resistant PCO? Insulin resistant PCO means, see, insulin has a very nice relationship with androgens, estrogens, and progesterone. Means insulin has a very nice relationship with ovarian functioning. Okay, but if the insulin increases in the body, why does the insulin increase in the body? The insulin increase in the body if its need increase, or otherwise if your body sense that the insulin is not sufficient to take care of my need. In the sense, let me explain you that what is the function of insulin. The function of insulin is glucose metabolism. Yeah, it is glucose metabolism. Now, when the glucose metabolism gets affected, for example, you have 100 grams of glucose, okay, and you, for that 100 grams of glucose, you need 10 units of insulin to digest it. These are arbitrary numbers, okay? So don't cram them. These are just the arbitrary numbers. So you have 100 grams of glucose and you need 10 units to digest them, okay? What will happen? Your body will produce 10 units for 100 grams, 10 units for 100 grams. Now, it happened that you have 100 grams of glucose and you could not digest it with 10 units. So your body will increase it to 12 units. Still, it didn't get digested. It will increase to 14 units. So slowly, what is your body trying to do is your body is increasing the level of glucose. And what's happening here is no matter how high the insulin is, your body is unable to use that insulin. Okay, your body is unable to use the insulin and digest the glucose. So you are ending up into hyperinsulinemia. Hyperinsulinemia means increased insulin in the body. That is hyperinsulinemia. When you have hyperinsulinemia, that results into altered function like hyperinsulinemia will lead to increased androgen secretion in the body. Okay, you will think that why hell the androgens, but the androgens are very naughty hormones. They will find their way and they will release. Okay, so there is again a cascade associated with it. That cascade is of the sex hormone binding globulin cascade, but not going in detail of that. So we can simply remember that when the insulin increases in the body, it triggers the increase of androgens. And when the androgens increases, they will reduce the functioning of estrogens and progesterone, leading to PCOD. Okay. Also, the insulin will increase the fat cells in the body. Okay, they will increase the fat cells in the body by altering the functioning of cytokinins and leptins. So the female will become obese. More is the obesity, more is the insulin resistance. More is the insulin resistance, more is the insulin. More is the insulin, more is the androgen. More is the androgen, more is the PCOD dysfunction. So that is the second type of PCO. The third type of PCO is the post-pill PCO or post-pregnancy PCO. Post-pill PCO or post-pregnancy PCO. What does that mean? That means whenever a female is upon, do you know that the oral contraceptive pills, whichever are being advised for a female for family planning, or it can be to take care of the other distresses. Okay, so all these pregnancy pills which are available, or oral contraceptive pills, what are those? These are the combination of artificial hormones. So you have artificial hormones, the estrogens and progesterones, which are the synthetic products into your body. And when you are upon a long-term external hormones, your body will forget to make the essential hormones. So when you stop taking the external hormones, your body will go into pituitary inhibition. It will go into pituitary inhibition. And that pituitary inhibition leads to characteristic features of PCOD, or or alterations into your ovarian function, resulting into PCOD. So that is and it is also common post-pregnancy, because when a female gets pregnant yes, Dr. Jaswinder.
No, nothing.
Okay, yeah. So when a female gets pregnant, again during the pregnancy and during the time of the child breastfeeding, during pregnancy and during the child of breastfeeding, during the time of breastfeeding, her body will not produce enough amount of FSH hormone, enough amount of hormones to have the periods regularly. So even post, you might have seen many females that it was easy for them to conceive for the first time. They got married at 25 and then they got pregnant at 27 and they delivered and it was all fine. And now after 5-6 years, they want to have the baby, but now they are diagnosed with PCOD. Have you come across such females? They were all good earlier, but after the first pregnancy and after everything, now they are being diagnosed with PCOS. That is an acquired one. I mean, it wasn't there earlier, but their body had acquired it. Maybe due to the pregnancy changes and maybe due to the other hormonal changes. There are the post-pill or the post-pregnancy PCO. And the fourth type is the chronic inflammatory PCO. What do we mean by chronic inflammatory PCO? Chronic inflammatory PCO means when your body is under chronic inflammation and there is an associated genetical disorder with it. So chronic inflammation will release cortisols and the androgens, resulting into PCOD finding. So that is these are the 4 types of PCO: insulin resistance, stress induced, post pill, or chronic inflammatory.
Ma'am, can you explain the insulin resistant again in short?
Yeah. So in insulin resistant PCO, what happens is, where does your body ends up into insulin resistivity? Your body ends up into insulin resistivity because of multiple reasons like obesity, diabetes, or the hormonal imbalance itself. So when the insulin increases in the body, it affects the functioning of sex hormone binding globulin. Okay, and that is responsible for altering the amount of androgen in the body. So since the insulin is high, it triggers the release of androgens in the body, and as the androgens increases, they affect the ovaries and leads to PCOD.
Thank you, ma'am.
Yeah, welcome. So these are the types of the ovarian, these are the types of the PCOD, which happens these are the types of the PCOD. Okay, so if a female has PCOD, what will be their characteristic finding? How will you find out that the female has PCOD? How will you find out? So she will have, like, what are the diagnostic criteria to terms a female as PCOD? So the diagnostic criteria according to the Rotterdam criteria. Okay, how can you diagnose a female to have PCOD according to Rotterdam's?
She'll have irregular periods,
Yes, irregular periods,
facial hair,
okay.
and
Obesity.
Obesity.
yes.
Obesity is one of the feature, but not very deciding, because now the lean PCO is also very common. Okay, so according to Rotterdam criteria, to diagnose a female, 2 of the 4 criteria should be fulfilled. Okay, 2 of the 4. Which are the 4? N ovulation and amenorrhea. There is no ovulation, there is no periods. First criteria. Second criteria, increased insulin in the body. That is second criteria, increased insulin in the body. Okay. Third criteria, presence of multiple cysts in the ovaries on ultrasound. So when you are doing ultrasound, you are finding out multiple cysts in the ovaries. That is the third criteria. And fourth criteria is either the blood report showing high androgens in the body, or the female is showing characteristic features of excessive androgens like baldness, hirsutism, obesity, acne, irritability, all these things. So if any of 2 out of these 4 are present, that means it is a PCO. Okay, so yes, I will repeat. So which are the 4 criteria according to Rotterdam? ROTTERDAM. You can write the name Rotterdam. ROTTERDAM, Rotterdam criteria. There can be 4 things to diagnose a PCO. First is N ovulation or amenorrhea. There is no periods. Second is insulin resistivity or hyperinsulinemia. Third is presence of multiple cysts in the ovaries. Multiple means how many? More than 12 cysts in the ovaries. More than 12 follicles, if you are seeing in the ovaries. That is the third. And fourth one is either increased androgens on the blood report, or there are signs and symptoms of increased androgens like obesity, baldness of the scalp, excessive hair growth on the face, mood swings, irritability, all those things. Okay, so if any of any of the two of these four are present, that can be considered to be as a PCO by a PCO patient. Clear now?
Ma'am, to know the insulin level in the blood, which test should be done?
So they generally do the HOMA-R. So it is a test to find out the insulin resistivity in the body. But it can also be HOMA-IR. HOMA-R is the name which tests that what is the level of insulin in the body, diagnose them as an hyperinsulinemia. But generally, most commonly done is even a GTT or just a sugar blood sugar test, so as to find out that do they have an increased amount of sugar in the body, and then they will check the insulin.
Okay.
Yeah.
Okay, thanks.
Most welcome. Clear so far?
Dr. Thara,
Yes, doctor.
I'll have to leave actually. I have a meeting. So I'll get the recorded link and go through.
Yes. You will be getting the link. Yes.
Okay. Thank you.
Yeah, most welcome. Yeah. So now when we talk about the other, so this was one diagnosis which affects the ovary. What are the other diagnoses which can affect the ovary? What are the other diagnoses which can affect the ovarian function? So the other diagnoses which can affect the ovarian function, those are the, as I said, POI, which we just discussed with Dr. Ritu, that is primary ovarian insufficiency or premature ovarian failure, where the ovaries, they fail to produce the follicles, or they fail to mature the follicles, not produce. Yeah, that is another diagnosis. Other than that, ovarian cancers and ovarian torsion. What do we mean by ovarian torsion? What do we mean by ovarian torsion? Yes, anyone? Okay, twisted. Yeah. So when the ovaries, yes, change position and twisted, okay, both the answers can be justified in this way, that when, see, the ovaries is covered with the mesosalpinx and is associated with many ligaments. Now, when the ligamental support of these ovaries, or when the mesosalpinx of these ovaries, the ovary gets coiled inside its own structure. So it gets coiled inside the mesosalpinx and surrounding its ligament, and it gets coiled, it gets strangulated inside. That is known as a ovarian torsion. The ovarian torsion, the name itself suggests that the ovaries has gone into a complete torsion. And ovarian torsion is actually a medical emergency. Why it happens? Its cause is not known, but it is a medical emergency. Why medical emergency? Because the pain is very severe. The female might come up with an lower abdominal pain, which is not really reducing or revealing by doing anything. So she has a severe ovarian pain, which is there no matter what you do, or a severe lower abdominal pain, which is there no matter what you do. And it is so bad that she cannot just stand, she cannot just do her activity. So when she will be presenting into a OBGYN clinic, they will do an ultrasound and they might find out that, okay, there is an ovarian torsion. So they have to undergo a laparoscopy. Sometimes the torsion is so bad, sometimes the torsion is very mild. So they just release the areas which are giving torsion and things are fine. Sometimes the torsion is very bad. So very bad in the sense it has coiled completely surrounding the ovaries and the fallopian tubes and all those things. So in that case, they might have to undergo oophorectomy and salpingectomy. They will cut the ovaries and the salpings, that is the fallopian tubes, and they will suture. So that is the oophorectomy and salpingectomy, which might be a possibility in the cases of ovarian torsion. So that is the another pathology associated with the ovarian functioning or ovarian torsion. Okay. After the ovaries, the next thing which comes is, see, the ovaries has released the egg. What was the function of ovaries? To release the egg. So the ovaries, they released the egg. Now the egg has come into the fallopian, where will be the egg be?
Fallopian tube.
Fallopian
tube.
So the ovaries, the egg will be into the cavity or the space surrounding the ovary. Okay. So the ovaries are they are not attached. So a thing here which is wrong is this. Yeah. So the fimbriae are attached to the ovaries. This is wrong. This is not the presentation how it is. The ideal presentation is, if this is the ovary, if suppose this is the ovary, the fimbriae are surrounding like this. They are freely floating surrounding the ovaries, and during the ovulation, the fimbriae will cover the ovaries. Okay. So when the ovaries will release the egg, that egg will be surrounding the ovaries, and the fimbriae will engulf the egg. Okay, they will engulf the egg, and then it will be transferred to the fallopian tubes. The egg will be then transferred to the fallopian tubes. In the fallopian tubes, it will wait for conception. Okay, in the fallopian tube, it will wait for the conception. So that is the function of the fimbriae. Now, after the fimbriae comes the fallopian tubes. So how are the fallopian tubes? Let me show you. You all can let me know when you want a 5-minute refreshment break, okay? Because it is a one whole day, and I can understand that it is to sit and to listen and to be passive is it is a very tedious work. So in case if you need a 5 minutes break refreshment, you can let me know. Yeah, all of you. So when we talk about the fallopian tube, how are the fallopian tubes? So the fallopian tubes are like this. I'll get black marker also so that I can use both the markers interchangeably. So these are the tubes, and inside the fallopian tube, okay, inside the fallopian tube, we have the hair-like projection. We have finger-like, hair-like projection, which are known as the cilia. Okay, so the internal of the fallopian tube, has the cilia. So this is the cilia. And what is the function of the cilia? The function of the cilia is to and fro. It will constantly move like this. So what it will do, the cilia will bring the egg towards the sperm. So suppose this is the egg, the cilia will bring the egg towards the sperm and the sperm towards the egg. Okay. and once they are united, or once there is a fertilization which takes place. Suppose now this is a fertilized egg. Okay. So once the fertilized egg happens, then the cilia will push the fertilized egg into the uterus. Okay, it will push the fertilized egg into the uterus. So that will be the function of the cilia. Okay, the fallopian tube. The fallopian tube is made, it is not like a hollow structure, but it has a moving cilia inside it. And this moving cilia are responsible for the movement of the ovum and the sperm. And then so suppose this is the tube. So like this, you have the cilia. And they are moving back and forth. Okay, so they are pushing the fertilized egg inside the uterus. That is the function of the fallopian tube. Okay, now what can go wrong in the fallopian tube? Have you heard about the terminology, which is this blocked fallopian tube?
Yes.
What is blocked
Yes.
fallopian tube? What is a blocked fallopian tube?
Congestion.
Yes, congestion or disruption in the continuity of the tube. So when the tube, which should be patent, okay, it should be patent, it is not patent. Instead, there is a fibrosis or an adhesion between the tube. Okay, a fibrosis or an adhesion between the tube, which is blocking the pathway, or which is blocking the lumen of the tube. It is blocking the lumen of the tube. This is the blocked fallopian tube. What will the blocked fallopian tube result into? The blocked fallopian tube can lead to infertility. Right? Infertility. The blocked fallopian tube can lead to infertility, one. Secondly, it can lead to ectopic pregnancy. Right? Ectopic pregnancy. It can lead to infertility or ectopic pregnancy. What do we mean by ectopic pregnancy?
Fertilization outside the.
Yes, when the fertilization does not take place into the uterus, instead it fertilizes into
Fertilization
the
of egg fallopian tube.
Yeah, the implantation. In the fallopian tube, all you need is fertilization. But if the egg, or if the fertilized egg or the morula starts growing inside the fallopian tube, that is known as an ectopic pregnancy. It is known as an ectopic pregnancy. Now, these two can be the causes, can result into, can be the consequences of a blocked fallopian tube. But the question comes is, what causes blocked fallopian tubes? Why does the fallopian tube gets blocked? Why does the tube gets blocked?
If the cilia are not functioning well.
Why will the cilia not function well?
Adhesion, maybe adhesion.
Adhesion. But why does the adhesion take? How does the adhesion takes place? So there are few theories behind it. First being infection, very common being infection. Okay, and in a populous country like India, the most common infection to happen into fallopian tube is tuberculosis.
Mm.
Okay, the TB, tuberculosis. So first being the infection, second being ectopic pregnancy. Ectopic pregnancy can lead to blocked fallopian tube, and even a blocked fallopian tube leads to an ectopic pregnancy. Okay, so there is a two-way relationship. Okay, how is a two-way relationship? I'll show you. Third thing,
How about the ethnicities?
sorry,
Ethnicities?
I didn't get that point.
Yeah. We have NAX.
Adnexia.
Yeah.
Yes.
Is that similar with the tuber fallopian infection?
No, adnexia is an anatomical part. I'll get a picture and show you that.
Okay.
Yeah. So, okay, infection, ectopic pregnancy, inflammation.
Yeah.
Okay. Fourth is injury. Okay. And injury. It can be, now how is the injury? It can, or it can be maybe a surgical procedure. Again, a surgical procedure can fall into the injury. Okay. Now, what do we mean? Why? What happens into these? So, when in the fallopian tube, because this is the fallopian tube, and in the fallopian tube, okay, when there is any infection or injury, how will the healing take place? The healing takes place through fibrosis. So there are chances that either the tube gets blocked completely, there is a complete blockage through to through, or
Narrowing.
there is a partial blockage. Okay. If there is a complete blockage, definitely infertility, because the egg and the sperm cannot meet each other.
Yeah.
Okay. But if it is a partial blockage, there are chances that the egg is here, but the sperm is very, very small in microns. So the sperm might come through this narrow lumen here. It might fertilize the egg. The egg is fertilized, but the diameter is big, and the egg cannot pass through the tube. So the egg will then grow here, resulting into ectopic pregnancy. Okay. Or this is a blocked fallopian tube resulting into ectopic pregnancy. Or the tube is all good. Tube is all fine. It is all patent, everything is good. Here there is an egg, a sperm comes, they unite and form a morula. Now, the ciliary movement is less. The ciliary movement of the fallopian tube is less, maybe due to low progesterone, or maybe due to excessive drug addiction, like alcohol intake, nicotine intake, any of these things. So which is reducing or which is compromising the ciliary mobility. So now the egg failed to reach their uterus. So instead of reaching the uterus, it got implanted and it grew here. And since it cannot grow further, okay, it cannot grow further, it broke. I mean, a miscarriage happened, resulting into again a blockage, a scar tissue, healed scar tissue. The female was not aware of this miscarriage. She just thought that, okay, she conceived and now it is not there. And then it blocked the fallopian tube. Okay. So an ectopic can also lead to a blocked fallopian tube, or a blocked fallopian tube can also lead to an ectopic pregnancy. Okay. Or maybe there is some infection. So the healing of the infection took place in the form of blocking. Or there is some injury. That injury can either be due to a surgical procedure, maybe a laparoscopy was required due to some other reason. A laparoscopy was done, which then like while coming out, it got injured. Or there can be even sometimes it can even happen that the female might have faced an an accident. So she was driving the bicycle. She fell down from the bicycle and she got injury into her lower abdomen. At that time things were fine. She started her routine and she was all okay. But then when she grew old and when she grew up, she realized that there is a blockage of the fallopian tube. So even an old injury or an external injury or an external the trauma can lead to an adhesion of the fallopian tube. Okay, so that is the blocked fallopian tube is a very, very, very common diagnosis of infertility. If you see the topmost cause of infertility, first being the PCOD, second being the blocked fallopian tube. Those are very common causes of infertility, the blocked fallopian tubes. Now, how can you diagnose a blocked fallopian tube? How can you diagnose a blocked fallopian tube? Yes, dear? Yes, Dr. Andy?
Ultrasound.
Okay, ultrasound, then?
How about the irregular period?
See, if the blocked fallopian tubes can still have regular periods. They do not have to do with the period irregularity. The female, even with bilateral blockage, can have a good period flow because the period is occurring due to the shedding of the endometrium. So the endometrium will shed on its own.
Okay.
Maybe hysterosalpingography.
Yes, hysterosalpingiography, very rightly said. So the first line of diagnosis after ultrasound is the HSG, hysterosalpingiography. Would you like to explain that to us, Dr. Nani?
Usually the doctor use some saline or liquid maybe shoot to the tuba.
Okay.
And with X-ray, we can see the liquid can enter the tuba or not.
Yes. So let me explain it again. So what happens into an hysterosalpingiography? What the gynec or the radiologist would do is the female will be into a lithotomy position, okay, and a gas or maybe a high volume liquid, a highly compressed liquid or gas. Generally, we are using the gas. Okay, so a radio opaque gas at a very high volume is injected inside the vagina. Okay, you can imagine that the female is into a lithotomy position and then radio opaque gas is injected inside the vagina. And then what will happen? So ideally what should happen? This, because it is at a high volume, it will be like pushed inside, like, okay, like it is like this, a forceful push. So when it is being pushed inside, the gas will travel through the vagina into the uterus, then it will go into the fallopian tubes and it will come out through the fimbriae if the tubes are open. If the tubes are not open, then the gas will enter the vagina, enter the uterus, and then will get blocked inside the fallopian tube. It will not pass out. So when the X-ray is taken, in that X-ray, only half of the tube is visible. Remaining half is not visible. So that means there is a blockage on that side. Again, HSG, hysterosalpingiography, is used as a therapeutic measure as well as a diagnostic measure for blocked fallopian tube. Why therapeutic? How therapeutic? So therapeutic in the sense that if there is a minor blockage, okay, you imagine a very minor blockage, then with a flow, with a forceful flow, the blockage will be removed, resolved. Okay, but if it is a major blockage, then it will not be resolved, and you will get the finding. You will get the finding or the output as blocked fallopian tube. So it can be used as a diagnostic as well as a therapeutic way to find out the blocked fallopian tube. Clear? You know what gives wonderful result into blocked fallopian tube is the fertility manual therapy. So visceral mobilization, visceral manipulation, fallopian tube restriction removal, all these things add up the are very much helpful to reduce the blockage in the fallopian tube. And there are articles which are showing a very good success rate with these maneuvers. So these are very good maneuvers to practice to resolve the blockage and the adhesions into the fallopian tubes. Okay. Yeah. And what does the doctors do? What does the gynec do? What is the another like if there is a blocked fallopian tube, what is the other thing the gynec would do? So they might use a laparoscope. They might go for a laparoscopic procedure. Again, laparoscopic procedure would be a diagnostic and a therapeutic. So they will insert the fiber optic camera and the caliper inside, the cable inside. They will visualize where the blockage is, and if the blockage is small, or if it is, if it is not showing any pathological symptoms, they might clear out at the same time. Then they will make sure that the fallopian tube has a very good the lumen is good, and there is no blockage. The patency of the tube is well established. Okay, it's like, this is the fallopian tube. You are inserting a small needle inside, a needle with a camera to view how it is. So it is like a laparoscopy. So you inserted and you saw that, okay, here there is an adhesion. You broke it, you absorbed it, and then you made the tube patent. Then they will pass saline 3-4 times from one side of the fallopian tube, and they will check whether the saline is coming out from the other side. If it is coming, that means the tube is patent. So that is the laparoscopy, which is done in order to diagnose as well as treat the blocked fallopian tube. Okay? Getting the point? Yeah. So then, So then the next thing is, after the blocked fallopian tube, the next thing which will come would be the uterus. Okay. The next is the uterus. What is there in the uterus? What's there in the uterus? So in the uterus is made up of perimetrium, myometrium, and endometrium. Okay, perimetrium, myometrium, and endometrium. And then you have the fundus of the uterus, the body of the uterus, and the cervix of the uterus. Okay. So the uterus has 3 layers: perimetrium, myometrium, and endometrium. And it has the fundus of the uterus, the body of the uterus, and the cervix of the uterus. Right? Now, what is the function of the perimetrium? So the perimetrium again is a protective layer of the uterus. Okay, it is the protective layer of the uterus. So it's going to protect the uterus, separate the uterus from the surrounding structure, and it will work as a shock absorbent. Okay. Next is the myometrium. Now, when we talk about the myometrium, that means those are the uterine soft muscles. The soft muscles or the uterine muscles are known as the myometrium. Okay, they are known as the myometrium. What is the function of the myometrium? What is the function of the myometrium?
Contraction and relaxation
Yes,
of
so,
uterus.
yes. So now when does the myometrium contracts and when does it relaxes? Aid in implantation menstrual cycle. Okay.
During labor and during menstrual cycle.
Yes, during menstruation cycle, during labor. Other than that, okay. So
Sexual activity.
yes, sexual activity. Other than that, okay. So let us first see when the myometrium relaxes. So the myometrium relaxes during pregnancy, and that's the reason why the uterus would expand, right? So the relaxation of myometrium occurs during pregnancy. Okay, and when does the myometrium contracts? So the myometrium contracts during menstruation. That's why you bleed. Okay, it contracts during menstruation, so you bleed. Secondly, it contracts during sexual activity. Why does the uterus contracts during sexual activity? The uterus contracts during sexual activity because it has to carry the sperm from the cervical area till the fallopian tube. See, your body, our body, why do we menstruate every month? You know, we menstruate every month because our body wants us to get pregnant. So it will try its best to get us pregnant. Okay. And since we will not get pregnant, it will cry, it will bleed, and we will have menstruation. Okay. So now when the female gets into a sexual activity, at that time, her uterus will contract. Okay, it is your body's natural way to increase the susceptibility of conception, to increase the chances of conception. Okay, so the contraction of the uterus will help to pull to carry the sperm from the cervical region till the fallopian tube. Okay, so it contracts, and that is the reason why many females. So if you are working with females, if you are working with yes, so that is the if you are working with females and if you are working with you're like maybe into antenatal, postnatal, exercise physiology, anywhere, you might come across many females complaining that madam, whenever I have a sexual activity or whenever I have an activity where I am able to reach the orgasm or where I am satisfied, I'm able to satisfy myself, after that I feel that I have cramps in my lower abdomen as if I'm menstruating. Have you heard this? Many females, they have uterine cramps post sexual activity. I don't know if any of you might have come across such cases, but that is because of the uterine contractions which happens during sexual activity. Another thing, when a female is able to achieve orgasm or when a female is into the sexual activity because she wants it to do and because she is willingly participating, at that time, at the point of orgasm, when she reaches the orgasm or when she is able to satisfy herself, at that time, her body will release oxytocin hormones, the love hormones, the oxytocin hormones. And the oxytocin hormones will also lead the uterine contractions. Okay, the oxytocin hormones will also lead the contraction of the uterus. So that is the function of the myometrium during the sexual activity. So firstly, the myometrium contracts during periods under the influence of prostaglandin. Increased prostaglandins will lead to contraction of the uterus. Secondly, during sexual activity, they will contract under the influence of the oxytocin. Third, during pregnancy. The myometrium contracts during pregnancy. Why do they contract during pregnancy? Not during childbirth, during pregnancy. So the myometrium contracts after like almost 28th week. Those are the false contractions or the Brixton-Hick contractions. Have you heard those words? Brixton-Hick? Yeah?
Yes.
Yeah, the
Yes.
false contractions or the Brixton-Hicks contraction. Why does the, sorry? Sorry? Okay. So why does the uterus undergoes Brixton-Hicks contraction or the false contraction? That is the way uterus prepares itself for the D-day, for the delivery day. Uterus has not contracted since 9 months. Okay. So it has to practice itself. It has to make sure that its force, its contractility, and all of these things are good. So after 28th week, a female can experience Brixton-Hicks contraction or the false contraction. How to say that those are false contraction? You can say them to be false contraction as these contractions are they are not increasing in frequency or intensity. Secondly, with change in position, these contractions will subside. So if you're having pain, if you're having like pains and you get up and walk, your pain will reduce. Or if you are having pain, you drink water and your pain will go. So these are changing according to the activity you are doing. That's why they are the false contractions. So that is the third time the uterus can contract. And the fourth time is during the actual delivery or the D-day. So those are the true contractions. So the true contractions will be very strong, very loud, and very forceful contractions. Okay. See, the uterus contracts the same at all the phases. Only the intention and intensity of contraction is different. During period, it contracts because you have to empty the uterus. You have to remove the endometrium. During sexual activity, it contracts because you have to get the sperm towards the ovum. During pregnancy, it contracts, that is its preparation going on. And during labor, it contracts, that is the spinal contraction to push the baby out. So the uterus, the myometrium contracts the same way, only the intention and the intensity of the contraction changes. Easy? Are you understanding?
Yes, ma'am.
Okay. Then comes the innermost layer, that is the endometrium. The endometrium. Now, when we talk about the endometrium, that is the innermost layer, and the endometrium is responsible for what is the function of endometrium? The function of the endometrium is
helping conceiving the baby.
Yes, it makes the ground for the flower to implant. Right? The endometrium makes the ground for the flower to implant.
Sorry, you are mute, Sarah, or my.
Sorry, dear. Okay. So the endometrium will make the bed, the garden bed for the flower implantation. Yes, so the egg can come and get implanted on it. That is one thing. That is the and second is to provide the nutrition to the growing fetus and the placenta. The endometrium will provide the nutrition to the growing fetus in the placenta. That is the function of the endometrium. And endometrium sheds every month and it builds every month. It sheds and it builds. So it grows under the influence of estrogen. It matures and becomes thick under the influence of progesterone. Okay, so that is the function of the endometrium. Now, after the endometrium comes the cervix. Can you see the cervix here? Can you see the cervix here?
Yes.
See now, more close. Can you see it? So this is the internal os. Just show it with a pen. Yeah. So this is the internal os and this is the external os. This is the internal os of the cervix and the external os of the cervix. So what is the response? What is the function of the cervix? So cervix has protective function, reproductive function, and sexual function. Okay, cervix has protective function, reproductive function, and sexual function. What do we mean by the protective function? So cervix works like a mouth to the uterus. It closes the uterus. So since it is closing the uterus, it does not allow the external harmful substances to travel inside the uterus, or external harmful organisms to travel inside the uterus. So the cervix works as a mouth. It will close, it will not be open. Okay, that is its protective function. Now, when does the cervix open? Any idea? When does the cervix open? Yes, any idea, anyone?
During periods.
During periods, right?
And
during delivery.
During delivery, right? Then?
And during the sexual intercourse.
Yes, during the sexual activity. So the cervix has to open when it wants to connect the uterus with the vagina, or when it has to, it is a door. So it will open, either something has to go in or something has to come out. So what has to come out? Blood during menstruation or baby during childbirth. What has to go in? Semen or sperm during the sexual activity. Okay, so the uterus, the cervix is, you can imagine it in that way, that the cervix is otherwise closed, but it opens during sexual activity, menstruation, and childbirth. So during ovulation, particularly during ovulation, cervix is open during ovulation. So why does the cervix opens during ovulation? Okay, so during, it has been said that otherwise your cervix is low and hard like your nose tip. Okay, you can touch your nose tip and feel your cervix is low and hard as your nose tip. But when you are ovulating, it is high, it is soft and open as your lips. So it is either like during menstruation, it is hard, like other days other than ovulation, it is hard as the nose tip. And during ovulation, it is open, it is soft, and it is high as the lips. Okay, so that it can facilitate with with conception. I said your body will try all things to make you pregnant. It's only you that you are not getting pregnant. Okay, so every month it just ovulate with one hope to get you pregnant. Yeah, that was on a funnier side, on a lighter note. Yeah. So that is the function of the cervix, that is the opening and the closing of the cervix. Now, as I said, the cervix play a protective role. So it protects the uterus. It also protects the growing baby, as the cervix remains closed throughout the pregnancy. It has a reproductive role. It gives the passage for the baby to get delivered. and it has a sexual role. Sexual role in the sense, sorry, reproductive role. It gives a passage to the baby to deliver. Second, it gives a passage for the ovum to for the egg to travel and reach the fallopian tube. Okay, and then it's sexual role. So how do we term that it's a sexual role? So sexual role is termed by this, that there are literatures, though not that common, but few literatures which are showing that many females, they are able to achieve orgasm when their cervix are stimulated. So during sexual activity or during sexual penetration, a deep sexual activity, if there is, if the cervix gets stimulated or if the cervix gets stimulus, it can lead to orgasm in a female. So that is its sexual role. So the cervix carry out the sexual role, the reproductive role, and the protective role for a female. Clear? Clear so far? Okay. Then, yeah, one thing I want to address here in the uterus, in the cervix itself, what are the common issues faced due to cervical dysfunction? That is the cancer, cervical cancer. January is considered to be the cervical cancer awareness month. Okay. Why do a female suffer through cervical cancer? Okay. Do you need a break for 5 minutes or we are good? Yeah, you need a 5 minutes break?
Yeah.
Okay.
Yes.
Okay.
Yes, miss.
Okay.
Yes.
Is it a unanimous yes from everyone?
Yes.
Okay. Yeah. So let us quickly take a 5 minutes break so that you can again focus and we can continue. Let's continue after 5 minutes. So it is 3 o'clock and 17 minutes here. So that I guess it is 4:37 there. Yeah.
Yeah.
So maybe we can start by 4:42 or something after 5 minutes.
Okay.
Yeah. Hello. Hello. Shall we start?
Yes.
Yes. So now we were talking about what are the most common type of or what can you consider as one of the most common dysfunction occurring at cervix? What can go wrong at cervix?
Infection,
Infection and
cervical cancer,
Yes.
cancer.
We were just discussing that cervical cancers are the a very leading cause of death. Yes.
After breast cancer, it's the second cervical cancer.
Yes, after the breast cancer, cervical cancers are the second most common cause of death in a female. And this is in cervical cancer awareness month going on. And there are a lot of females who are suffering due to cervical cancers. And it can happen that it is being diagnosed at a phase where it is not preventable or it is not reversible. Now, why does a female get cervical cancer, or how does a female get cervical cancer? So the pathology, so cervical cancer occurs due to what is the causative factor for cervical cancer? HPV virus, very rightly said. HPV, human papilloma virus. And human papilloma virus is the same virus which is responsible for moles and warts on the skin. So you have moles, you have warts on the skin. That is because of the human papilloma virus. But human papilloma virus has more than 200 variations into it. Do you know that every virus has a big family? The way the COVID virus is, I don't know how big its family. is, but similarly, the human papilloma virus is also having a very huge, like more than 200 virus. Some of the virus are non-cancerous, some of the virus are cancerous. Now, when a female gets in contact, or the cervix of the female gets in contact with the human papilloma virus, it results into the cancerous dysfunction, the cancerous growth. It can lead to cervical mutilation, okay, or and the cell differentiation. So here in the cervix, what we were seeing right now, from where exactly the mutilation can start. So if you can see here, yeah, can you see the cervix more better now? Yeah, I hope yes. So now this is, like you can see, this is the inside endocervix, and this is the ectocervix. Okay, this is the endocervix, and this is the ectocervix, and the junction of the endo and the ectocervix is the point where which is a potential site for the cancerous growth. So the cancerous growth generally happens at that site. That is the function. That is the junction of the endo and the ectocervix. Okay, that is junction of the endo and the ectocervix. Here, okay, and from here the genital mutilation starts and the cervical growth takes place. Okay. Right.
I just want to tell everybody that there are vaccines for cervical cancer, which females after pregnancy they can have. So the HPV, that vaccine contains this HPV virus itself, which can prevent cervical cancer. So mostly, most of the pregnant women, they don't know, and that time period left away. So this like one of the information which people, like we as a working in a medical field, we can give to our patient, prenatal pregnant ladies and postnatal.
Yes.
And there are 3 vaccines. First month, third month, and 6th month, they can take the course of that.
Yes. So very rightly said, Dr. Dolly. So when we talk about the cervical cancer vaccination, it is a drive which is run by the Indian government, and I'm sure there might be such type of drive which is being run by the Indonesian government as well. And almost like because it will be in the UNICEF for the UNICEF schedule also. So when we talk about the cervical cancers, there are different types of cervical cancers vaccines which are available. Some of the vaccines in India, we have 2 major types of vaccines which are available. Those are the bivalent vaccines and the quadrivalent vaccines. The bivalent vaccines are the vaccines which are providing the protection against only 2 variations of HPV virus, and quadrivalent are providing protection against 4 different variations of the HPV virus. And ideally, the vaccine should be taken, like, what is the youngest age a female should get vaccinated is after her puberty. And it's not only the female, the male should also be vaccinated. So this vaccine drive, the HPV vaccine drive, should be done, should be like the HPV vaccine should be taken by a male as well as a female, both of them. And you can have a vaccination anywhere from the 9 years onwards. Means once they are into the puberty, they should get vaccinated before they start their first sexual activity. Okay. Because why? It's not so that you cannot get vaccinated, as Dr. Dolly said, that you can get vaccinated even after pregnancy. Yes, you can get vaccinated. There is no harm in doing it. But the potency or the the viability of the vaccine is higher if you are doing at before a sexual intercourse. Why? Because suppose like you are already 34 years old, you are a mother and all. So there are chances that by this time, due to your sexual activity or due to the insertions and all, you might have already come in contact with the virus. So your body, like your body will not be that immune to the virus if it has already contracted it. So the earlier or a younger, or if you're doing it at a younger, that is more advisable rather than doing it later in the age. But if you are not vaccinated, you should definitely get vaccinated for HPV, because it is providing a good protection against the cancer. Thank you, Dr. Dolly, for the information.
Welcome, ma'am.
Yeah, Dr. Nani, are you asking something?
Sorry, I am sorry.
No problem. I thought you are asking something, but your voice was not clear. Yeah.
Doctor, you said कि vaccine should take before first intercourse or first sexual activity, and after that there is no point to take that vaccine.
No,
or you can have.
No, you definitely can have, but it's how shall I say? It's like that see, when a female has not yet started her activity, her at that time, if you are giving the HPV virus, what will be there in the HPV virus? There HPV vaccine, there will be non-virulent HPV viruses, right? So they will be non-potent, immobile viruses. So they are not going to damage the body, but the body will be able to produce the antibodies against it, right? So that is the time, like you are introducing an a naive virus to the body, so the body will respond according to it. But if after sexual activity, for example, I am married, I'm having a baby, and now if I am vaccinated though, but suppose if I take a vaccine now, and before me taking a vaccine, suppose I have already got an HPV infection. We never know. My husband, my partner would be an HPV positive. We don't know. We are not that, nowadays people are getting more aware and they are doing the things. And since we are educated, we are taking care of these activities. I mean, this type of health precautions, but not all. So suppose by any chance, if I have already contracted the disease, the virus, then the vaccine will not be